Hunter is a consultant ophthalmologist and with Hong Kong Eye Hospital. He has more than 70 peer-reviewed publications and book chapters. He is at the moment current president of Asia Pacific Society of Ophthalmic, Plastic and Reconstructive Surgery. And as you can see, he had an APO travel grant in 2010 and honor awards and service awards from APO. So I'm going to start playing his video recorded presentation. Dr. Hunter is here to answer any questions directly, but he is going to talk on nasal endoscopy in congenital nasolacrimal duct obstruction.
Good evening, everyone. This is Hunter Yuen from Hong Kong. First of all, I'd like to thank the APSPOS and Dr. Surendran for the kind invitation. And this evening, I'm going to share with you my experience of using nasal endoscopy in the management of congenital nasolacrimal duct obstruction. And I have no financial disclosure. As we all know, congenital NLDO is a very common occurrence, and it actually occurs up to 6% of the infant. And there is no sex predilections. The typical presentation include tearing, periocular skin changes, regurgitations, pustular discharge, or in some cases, acute cystitis. We all know that congenital NLDO is most commonly due to a membranous obstruction at the valve of Hessner's, which is over here, the entrance of the nasolacrimal duct onto the nasal cavity. But bear in mind that the other possibility do exist. Patients with a tearing can be due to obstructions in other part of the nasolacrimal system. So obstruction of the valve of Hessner is not the only cause of congenital nasolacrimal duct obstruction. Other possibilities as listed here, including dacryocystosis, and should be considered in the differential diagnosis list. Secondly, we should bear in mind that anatomical variation do exist. Typically, the sac duct junction open at the inferior meatus. But nevertheless, there are some anatomical variation. The nasolacrimal duct may extend down the submucosa for several millimeters or end up in other area of the nasal cavity. It may also end blindly in the medial wall of maxillary sinus, or in some cases, there could be complete absence of the nasolacrimal duct because of the osseous nasolacrimal canal did not develop. If you are not doing a nasal endoscopy, now all these things will not have been picked up. We know that if the patient is presenting with a congenital NLDO, typically we will start conservative management, observe, massage. Topical or systemic antibiotic can be considered if the patient is having infections. Of course, if the patient is having failed conservative treatment, we will consider syringing and probing. Typically, if the patient did not have a severe episode of infections, we will perform the syringing and probing at the age of 1. But the reason for us to do at the age of 1 is because it has been shown that if you defer the syringing and probing, the success rate may drop with time. So typically, the optimal timing is at around age 1. Nasal endoscopy is very helpful, at least in my own view, in the management of congenital NLDO. It allows you to have a direct visualization of the nasal cavity. Nasal pathology can be picked up and also managed accordingly. Even if the patient is not having nasal pathology, if you are doing the syringing and probing or other intervention, this will allow you to ensure proper location and proper placement of the equipment. Say, for example, if you're doing the probe, if you can see the probe over the inferior meatus at the normal opening, you know that you are not having a false track. So direct visualization over the nasal cavity during this procedure is very helpful. This is a very special type of a nasal endoscope with an adjustable angle, which allows you to look at the different position and different area without the change of the nasal endoscope. Let's look at a case. This is a 3-month-old child who presented to us with an infected dicryocystosis. He was treated with a topical as well as a systemic antibiotic with some improvement, but this mass persists, and therefore surgical intervention is needed. And in this patient, we decided to perform a probing under general anesthesia with the help of a direct nasal endoscopy. The patient was placed under general anesthesia, nasal packing. We put the nasal endoscope, we look at the nose. There were no anatomical variation. We look at the inferior meatus, and then we do the probing. When we are doing the first probe, we did not see the probe over the inferior meatus. So we noted that in this case, the first probe was actually in a false track. And therefore, we take out the probe and then we re-probe again until we saw the probe over the inferior meatus. As you can see here, we know that we are in the correct position. The obstruction was then perforated, and with the digital pressure over the nasolacrimal area, you can see all the pustular discharge was drained through the nose, and the patient was symptom-free after the procedures. As you can see, this is before the procedure. This is immediately after the procedure. There was no cutaneous wound, and this is the appearance 1 week after the procedure. Patient did not have a tearing afterwards. Now, if nasal endoscopy were not done, actually we may end up in false track, and then we may not be able to reprobe, and then the optimal outcome may not be achieved so nicely. Nevertheless, you can argue that I can do a nice syringeal probing without nasal endoscopy. But if nasal endoscopy is not done, definitely you will miss this condition, which is called dicryocystosis, which is a cystic dilatation of the lacrimal sac over the nasal cavity. But this is what you will see. This is a dicryocystosis. The proper management is that what you have to do is to have a direct visualization. You have to incise through the dicryocystosis and also remove the mucosal lining such that the opening is enlarged, and then the tear and also the mucous discharge can be drained onto the nose. Now, this is what you will encounter if you are not doing nasal endoscopy. You put your probe in, and then you said it's okay, you hit the bone, and it's then perforated, but when you do the syringing, it's still not okay. So what you need to do is that you tether up the dicryocystosis, and then you use your blade to make an opening, and also to remove the nasal, the overlying mucosa to have a huge opening, large opening, before you can treat this condition. This is another condition that nasal endoscopy is particularly useful, which is called Berry probe. As I have mentioned, it is a type of anatomical variation. What happened is that the nasolacrimal duct did not open over the inferior meatus as an opening. It travels onto the submucosal area. So when you encounter this condition, you need to have direct endoscopic visualization, and then you move your probe medially, and then you use your sickle knife to make an opening as shown here. The success rate of a syringeal probing, now even without nasal endoscopy, was reported up to 70 to 90%. But people feel that if you are doing direct nasal endoscopy during the procedure, this could actually enhance the success rate. And as I have mentioned, direct visualization can ensure proper procedure and also reduce trauma over the nasal cavity. If the first probing is failed, what you need to do is to repeat the probing about 2 to 4 months later. If the second probe is failed again, other treatments include silicone tube intubation, balloon dacryloplasty, or endoscopic DCR, and all these procedures. And I think nasal endoscopy is very helpful. This is a schematic diagram showing you different types of intubation, including the crown force system, the Riddling system, and other systems. The Riddling system was designed such that when the silicone tube is being retrieved through the nose, it's a soft proline suture that is attached to the silicone tube. And this is hoping to facilitate silicone tube removal and to reduce surgical trauma. But if you are doing the intubation under direct endoscopic control as shown here, definitely the trauma will be reduced and the silicone tube retrieval will be much easier. So silicone tube intubation assisted by nasal endoscopy is helpful. Balloon dacryloplasty is another procedure that is very popular. And if I'm doing that balloon dacryloplasty, I also do it under a direct endoscopic control. So the procedure, syringing, probing, probe through the obstruction, you put in the balloon, and then you position the balloon. And if you can do direct endoscopic control, then you can see the balloon that is situated nicely over the normal opening. And now the saline is being injected over the balloon to inflate the balloon. And then typically we do the 2 cycles at 2 levels. The first is 90 atmospheric pressure. The second cycle is 60. And after the procedure, as you can see, fluorescein dye can be passed through nicely through the anatomical opening. So nasal endoscopy is also helpful when you are doing balloon dacryloplasty. So these are some of the advantages of balloon dacryloplasty as compared to a silicone tube intubation. The greatest advantage is that there is no need to remove the silicone tube if you are doing the balloon DCP. Of course, nowadays, we are having newer type of the silicone tube intubation, the push type of a silicone tube, including the Mastaka stent or the Nunchaku stent. If you are doing these type of silicone tubes, I think the procedure will be easier. The silicone tube removal is easier as well. But of course, if you are doing the traditional type of intubation that you want to retrieve the silicone tube over the nose, then nasal endoscopy is helpful. Of course, there are some refractory cases, failed probing, failed balloon, failed intubation. In this situation, DCR may be needed. And personally, for pediatric patients, I also consider endoscopic DCR as one of the treatment options. So this is a kid, congenital NLDO, failed other measures with a recurrent dacryocystitis. And in this situation, I did the endoscopic DCR. Now, basically, the procedure is quite alike to that of adult, except that the nostril is a bit smaller. The youngest patient that I have performed endoscopic DCR is 1.5 years old. And I think, of course, for those patients less than 1.5, very, very small child, then endoscopic DCR may be difficult. And of course, if needed, you may need to have other treatment options, as I have just mentioned, or defer the procedures until to the stage that you can perform an endoscopic surgery. So endoscopic DCR is also possible in pediatric patients. So to conclude, I think that nasal endoscopy will facilitate the surgical intervention in congenital NLDO, probing, intubation, balloon, and DCR. All these will be facilitated by nasal endoscopy. Remember that some of the nasal pathology can only be picked up with the use of a nasal endoscopy. And nasal endoscopy is very helpful, especially for those cases who has a failed probing. I understand that many pediatrics ophthalmologists may not be familiar with the nasal endoscopy. So I think it's perfectly fine if you do the syringe and probing without nasal endoscopy. But if the patient is having failed probing, then personally, I feel that nasal endoscopic assisted intervention will be helpful. This concludes my talk. I'd like to thank you all of you for your kind attentions.